Welcome to the International Arrhythmia School session focused on arrhythmia and alcohol. We are very happy to have so many of you online. We kindly remind you that making recordings or screen captures is prohibited. Please note medical practitioners may discuss techniques or products that are not available in all geographies. We are recording this session for educational purposes, so if you prefer to remain anonymous, you can pose your questions through the chat function in your Zoom control panel. Our moderator will pick up these questions and pose them at an appropriate time in the presentation. During the Q&A session, at the end of this health professional session, it is also possible to ask your questions live through audio. Please indicate you would like our technical team to open up your microphone by using the raise hand function. You will find the raise hand function under reactions in the Zoom control panel. Our technical team will then open up your microphone, after which you can unmute your microphone. Once you have asked your questions, please do not forget to mute again. We encourage you to use the chat functions as much as you like. Should you drop off from the event, please know that you can always get back in using the same link. It is now with great pleasure that I hand over the microphone to Dr. Eugene Crystal. The stage is yours.
Thank you. Do you hear me well? I want to welcome everyone. For those of you who don't know, I am a cardiologist with special interest in arrhythmia, and I am professor of medicine at University of Toronto. I am associated with two major hospitals in the city, Sunnybrook at Women's College. With me during this conference will be several of my colleagues, and they will be introduced as they come in. This event of Arrhythmia School is existing now for 19 years. The history of it is plain and simple. The history of arrhythmia treatments was changing very quickly in 90s and around 2000, and there was a major gap in Canada in terms of educating medical practitioners of all levels. And that around that time we established this school. And as I was hearing many of my colleagues' presentations, I frequently thought that not only I need to share it with my colleagues, but also with my patients. And eventually the idea was that we should bring patients to the same room as professionals working in the field. And that's what's happening at the winter school today. As you know, I also have a large practice, and I think amount of questions coming from patients, about treatment of their disease and their conditions is tremendous, and it's a good opportunity for us to try to address many of these questions in a meaningful, I would call, small class teaching, what we call in university. A couple of disclaimers. This Arrhythmia School is a non-profit organization, and also if you would go on the website, you will see several sponsors, except Women's College sponsorship and Sunnybrook support. There's no corporate sponsorship for patient-related events at all. I want to clarify that this event is coordinated by Meeting Pulse team from Netherlands, who supported our online venture for a long time now. And without further ado, I will introduce my close friend and colleague Adrian Baranchuk, who is professor of medicine and cardiology from Kingston. He is a specialist in cardiac arrhythmia. He was born and raised in Argentina, and he joined Canada around the same time I came to Canada, roughly, probably plus minus a couple of years. We share friendship, we share our understandings of many issues, but also controversies. We also share one important thing is both of us are not first generation doctors in the families, which makes us I would say a little more careful about what do we do to our patients and what we say to our patients. I want to share a little small funny video, which some of you may not find funny. The video called No Red Today. The video is, by the way, having no voice. So you see a cellar, probably relatively new cellar, because there's more wine on the background. And this is a capture of security camera. Yes, Adrian, I know, I know what we feel. So my point of this video is that also many of us enjoy alcohol, and I hope many of us will still be able to enjoy alcohol. We need to take a good care of it. And I will pass it now to Adrian.
Well, thank you very much for the introduction, Eugene. That was a kind of painful video to watch. So thank you for setting up the tone for the presentation. I'm going to share my screen. And in the next 20 minutes, I'm going to try to make a case on what do we know about the relationship of alcohol consumption and cardiovascular health, and more importantly, associated with cardiac arrhythmias, which are disorganizations of the cardiac rhythm. As Eugene said, for this session, we are going to take questions at the end. Then there will be a second session specifically oriented to answer questions from the patients. So if there are patients in this room, you're also welcome to ask now or to attend the next session. This is entirely up to you. I want to start saying that I became an habitual of the Winter Arrhythmia School, and every year we wait our in-person meeting with hope to see each other and to share. And I hope that 2022 will give us that opportunity. Let's see how things are moving. But of course, we will be there supporting this initiative that we like so much. So these are my disclosures. Specifically for this presentation, I have no disclosures to make, but I want to thank the International Arrhythmia School organizers for all the effort, time invested, and to put in this interesting program. Please don't miss the presentation of my colleague, Dr. Bill McIntyre. That is going to be fantastic. I'm going to then do a review of alcohol and cardiovascular health. At the end, I will show you how much we cardiologists know about this. I'm going to review the concept of the standard drink. We will see the recommendations of the AHA, and I will make special emphasis in the relationship between alcohol consumption and cardiac arrhythmias, basically the relationship between alcohol and atrial fibrillation, which, as you know, is one of our pandemic conditions. My involvement with this topic started a few years ago when we put this in-depth review for circulation, where we started analyzing what is in alcoholic drinks, and more specifically in wine, that could impact the cardiovascular system. And as the studies that are available are purely observational, you will find no randomized control trials, and the little randomized control trials that exist are very poor in methodology. Our first attempt was to understand the substance. And as you can see, there are many substances in a glass of wine, some of them with direct impact in our cardiometabolism. For example, drinking wine is drinking sugars. So if you're embarked in a diet, and I will make some emphasis on that, for losing weight, as Dr. Crystal is currently doing, you can see the great results. It's important to understand how much calories and how much sugar you're going to drink in every glass of wine. Then ethanol deserves a separate talk, because ethanol is what produces that wine has a bimodal physiological impact over the cardiovascular system. When we drink ethanol at low concentrations, it improves the function of the endothelium. It produces vasodilation. So in summary, reduces inflammatory triggers, induces proper anticoagulation. So basically, at low doses, the ethanol could be a substance that should integrate part of the things that we recommend to patients. But it has the particularity that when you cross that threshold, first you have an attenuation of the benefit, and then you have a drastic reduction of the benefit and increase of the risks. And this is why wine will never be posed or should be posed as a substance that improves the cardiovascular profile. It does it when you drink it properly, but as you cannot control the dose, you should not advertise it as a substance with positive effects on your cardiovascular system. And then we go through the phenols, which we have flavonoid and non-flavonoid substances. And I just mentioned maybe the most important ones in terms of concentration, of which resveratrol has called the attention of several investigators due to its properties to improve endothelial function, reduce inflammation, improves oxidation, and improves coagulation patterns. So in these flavonoids are not only in red wine, but are also in fruit, vegetables, and tea. And the mechanism of action is reduce the oxidation of LDL. This decreases platelet aggregation, improves endothelial function, and it has a very potent antioxidant and anti-inflammatory property that, of course, I don't need to say this to a group of doctors here and nurses, that reduces mortality due to ischemic heart disease, delays or reduces the process of atherosclerosis, and improves coagulation, improving your cardiovascular profile. So we put this figure in the original circulation paper to show how each one of these 5 big ones, improving lipid profile, inflammation, endothelial function, coagulation, and glucose uptake. Please pay specific attention for diabetic patients drinking at low to moderate doses. There is an increase of insulin-mediated glucose uptake, which improves dynamics of insulin. Of course, one of the things that happens with ethanol is that if you drink in excess, this is completely reversed, and drinking in excess, being a diabetic, is quite problematic. And these are the 4 factors basically that improve your cardiovascular profile. So when we move then to how much we should drink, there were huge efforts as the one of the WHO in advancing the definition of a standard drink. I don't know you guys, but when I have to calculate something on medicine based on a formula that has 2 X's in between with a conversion factor, you lost me. You lost me. I don't know exactly how to define that. But what I can say is that 140 milliliters of wine equals 1 glass, the type of glass that you receive in a restaurant. After the publicity of all this work in places like the Washington Post or the Time magazine, I have hundreds of patients coming to my office saying, you are saying 1 glass. Is this glass what you're talking about? And they show me something that looks like a fish pot, right? I say, no, listen, we need a better graphic. It's like a glass that you receive in a restaurant. Beer, 330. Remember that the business of beer has increased the size of the beer can to 500 milliliters, almost at the same price of the 330. It's a matter of cents. They make a lot of money by giving you more alcohol. And spirit, 40 milliliters is 1 shot, all right? So we needed better imaging than a formula for the standard drink. It's quite clear that if you decide to do wine, you will obtain better beneficial substances in red wine than in white wine, and that is a 10-fold higher concentration of polyphenolic content. And this is something that we published in BMJ, where the standard drink has variations depending where you live, from 13 grams of pure alcohol for Canada to 19.7 grams in Japan. And I can see now Dr. Crystal preparing his luggage to relocate in Japan. So the standard drink takes a different perspective. So the doses recommended by the American Heart Association, and this is something that when the International Arrhythmia School invites me in 2022, I could hopefully be discussing again. We submitted, and it's under revision, a paper called Alcohol and Women, Unpacking the American Heart Association Guidelines. When I say guidelines, this is not a single document. This is 12 documents over time that say exactly the same thing. For men, 2 glasses a day, living 2 days free of alcohol. For women, 1 glass a day, living 2 days of no alcohol a week. So why this gender segregation to report benefits? Don't get it wrong. This is not a restriction in the excessive amount. It is a gender segregation based on benefit. And you may remind me if, for example, aspirin, statins, ARBs, ACE inhibitors are given in different doses in order to have cardiovascular benefits between men and women. So we wanted to know why. And this specific substance is segregated differently. Things that quickly come to mind, and hopefully you will be able to read in that paper, hopefully in circulation, hopefully. Size. This is something so old, impregnated of social and political issues, that women are smaller than men. That could be maybe true 1,000 years ago. Now it's not true anymore. Liver metabolism, all stories, anecdotal reports with 6 patients that were quoted again and again and again. Observational studies full of confounders with very small number of patients, and you name it, everything that has been mentioned in those guidelines to support the segregation ends up in a simple analysis that has to do with social and historical perspectives. And this is the part of the report of the World Heart Organization, and they did this graphic that I was looking for. The can of beer, the single shot, the glass of wine. So this can be shared with the patient so they know exactly what we're talking about. In response to the original paper in circulation, we received plenty of letters. Some of them were published, giving us the opportunity to expand on the chemistry of wine. Remember, we're cardiologists, electrophysiologists, we're not chemistry doctors. So, but that forced us to look into more substances and more historical perspectives of how the alcoholic drinks became what they are today. And we put this in trends a couple of years ago, where we review exactly now each one of the substances and how alcohol became into the market despite all the negative things associated with it. And that allows us to go substance by substance. We learn, for example, about quercetin and the positive and beneficial aspects of it. So now I'm going to start going slowly into the arrhythmia concept. But first of all, and before we take the last paper as the best one, I could like to show you things that exist since I've been in this business. So in 2017, there was this population-based cohort study of almost 2 million people. So when you bring another paper, a new paper that is going to defy this, well, I'm not asking you to bring me another 2 million, but bring me at least 250,000, right? Not 200 people, because in 200 people, you may find things that they didn't see here. And what they did is they follow up patients for 6 years that at the time of entry had no history of cardiovascular disease, not taking any medication, not being recognized with anything. And they defined 12 types of cardiovascular disease, you name it, from ischemic heart disease, hypertension, heart failure, etc., including arrhythmias. Half of the team, half of the population were women. I'm not going to go through this detail, but basically low doses according to AHA guidelines of alcohol intake were associated with delay of or elimination of 12 different cardiovascular conditions. 2 million people. What's about the resveratrol? Resveratrol took over the rest of the substances because it's quite easy to isolate from utilizing complex chemical decomposition of wine. It has a very good bioavailability, so that means that you could create pills of resveratrol to use it as a potential drug with cardiovascular benefits. It's well demonstrated its antioxidant effect, impact over HDL and oxidation of LDL, impact on insulin sensitivity, associated with ischemic heart disease reduction. So when you want to know how much research is being done, you can either go to PubMed and figure out how many entries you have, or you can go to clinical.gov, and at that point, 4 years ago, there were 133 studies ongoing. And the other thing is, if the problem of alcohol is ethanol, why don't we remove the ethanol from alcohol? So I invite you to try the dealcoholized wine. This is something that people that is doing diets based on the calories provided by regular wine are taking to parties. I particularly don't like it, but of course it is much healthier than alcoholized wine. If you think that this is a niche, obscure thing, if you get into the business around the alcoholized wine, you will be surprised how much bottles a day of this product are being sold in the world. And of course, you may retain through this process all the substances that are of proved cardiovascular benefit, removing the ethanol, which is a significant contributor to benefit over the cardiovascular system when drinking in moderation. And this is what I wanted to show you, Dr. Crystal. A regular beer, 153, red wine, 125, dealcoholized, 30. So basically, for each glass of wine in terms of your diet, you could have a bottle of dealcoholized wine. I want to say here that if resveratrol is so good, why don't we put more resveratrol in wine artificially? What a great idea, Adrian, but someone had it before you. So what I did is I went to LCBO and bought a bottle of an artificially enriched wine with resveratrol. And that was quite similar to drinking a glass of a syrup or something that you could take as a medicine, not as a social drink. So there is an opportunity, and this does not exist, to naturally enrich wine with polyphenols, and specifically with resveratrol. And the process is complex and it is expensive, but there is an opportunity. Let's go to the alcohol and arrhythmias, the atrial fibrillation tail. I did this slide for my next presentation to show patients the difference between the lovely sinus rhythm, all regular with this lovely bump here called the P wave, versus atrial fibrillation, all disorganized. And the problem of atrial fibrillation, and Dr. McIntyre is an expert on this topic, is that it increases the risk of stroke. So while it deteriorates the dynamics of the heart, and that is a serious problem, the true serious problem is that if you have atrial fibrillation, the vast majority of the people with atrial fibrillation will have some significant increase in the risk of stroke. And you will find a lot of papers about this. And more lately, there were 2 or 3 saying and suggesting that a zip of alcohol increases the risk of atrial fibrillation. So let me see if I can put this into perspective. So basically, there are different types of effects of alcohol to end up in atrial fibrillation. So acutely, there are cellular effects that alter ionic channels and alter the electricity of the heart. But when taken in excess, alcohol also produces atrial inflammation, so the opposite of what I was saying. And while I said that ethanol is a potent vasodilator, taken in excess, it produces hypertension and increases intracranial bleeding. Taken in excess and taken late at night, it potentiates obstructive sleep apnea, both obstructive and central, and can, through these mechanisms, modify the histoarchitecture of your heart through left ventricular remodeling. That all creates the perfect combo for the what we call the atrial substrate or risk of atrial fibrillation. And then when you do acute binge, you can trigger the conditions to increase atrial fibrillation. And this is the slide of the day. Most of you, or some of you, may be familiarized with this red curve called the J curve, okay? That means that when you drink very little, your risk of total mortality decreases. When you arrive to 10 drinks, which is what the AHA recommends, 2 drinks a day, living 2 days free of alcohol a week, starts the plateau. And when you go into the 13 to 15 drinks per week, you start increasing your total mortality. This is accepted by everybody. Now look what happens, blue line, with the atrial fibrillation risk. Since you start drinking, the risk of atrial fibrillation increases. Can you see that? And increases, and it keeps going behind the picture there, increases. What I did is I add up there a big red line showing you the 10 to 12 drinks per week, which is what the AHA recommends. If you transpose this into this line here, the relative risk increase of atrial fibrillation goes from 1 to 1.1. Okay, I live in Kingston, you guys live in Toronto. I want to visit my friend Eugene Crystal, so I have to drive the 401. What is the risk of dying in a motor vehicle accident by me driving to Toronto? The risk increases from 1 to 1.1. Okay, don't drive, Adrian, take a plane. What is my risk of dying in an airplane crash? Increases my risk of dying that day from 1 to 1.1. And I could continue all day. Living in a city, breathing air pollution increases this. Being too stressed, doing presentations on a Sunday morning when you're supposed to be relaxing increases my risk of atrial fibrillation from 1 to 1.1. Indeed, Suzette is laughing, but I'm having palpitations as we speak. What I'm trying to say here is that living increases the risk of total mortality. That's the only certainty we have. We are all going to die, but we are going to live assuming certain risks. When the risks are from 1 to 1.1, which is the minor amount of increased risk that you can have, maybe you have to consider that to be happy, you will absorb that risk. All right, 16,000, now we're talking 16 years ago, 16,000 individuals is heavy alcohol consumption that is associated with the risk of atrial fibrillation, not the low consumption. You wanted a 250,000? I got you the 250,000 study. This is a meta-analysis, right, done by Preston Sanders, one of our colleagues with larger experience on triggers of atrial fibrillation. Low levels of alcohol intake are not associated with the development of atrial fibrillation. And then we move into the more newest component, which is, okay, for patients that we have done a lot of things. For example, more than one ablation to control atrial fibrillation. The frequency of alcohol consumption may be associated with atrial fibrillation recurrence after the initial cardioversion after the initial catheter ablation for paroxysmal atrial fibrillation, but not affect the outcome at the end. And we are saying to our patients that 1 in 3 patients with paroxysmal atrial fibrillation will come back to the table. Very nice. This study, 5 years too old, no differences in paroxysmal or persistent regarding alcohol consumption. And this is now more recent. This is a couple of weeks ago that triggered all this fuss. And the structure of these papers make very difficult to determine that the recurrence of atrial fibrillation is necessarily associated with a reduction of no reduction in the amount of alcohol. And now, when you separate reduction to no reduction, that is not how you measure this. And I apologize for a great journal to have published this, because you can reduce from a very excessive amount of alcohol to a less excessive, from less excessive to acceptable, or from acceptable to abstinence, which is what is being promoted these days, abstinence. And that is a little bit cocky in our end as doctors, thinking that because in a 10-minute interview, we are going to say to a person, you should drink 0 alcohol, the patient is going, yeah, is going to do it. I invite you to the next meeting so we can discuss this sort of negotiations. In this review we put with Dr. Klein from the Ottawa Heart and Professor Shenasa, we were identifying the different social risk factors. So in green, you're okay to go. In yellow, you should take a little bit of attention and read the material. In red, definitely the things that promote atrial fibrillation. And why, after all my presentation, we put alcohol here? Because there's no doubt that if you drink in excess, you produce atrial inflammation and atrial fibrillation. There's no doubt about it. What you have to do is to learn a little bit more about dosification and then learn what you're going to recommend to your patients. And here again, for those that want to read this recent paper, we put all the mechanisms that trigger atrial fibrillation. I think I described them before, but I could say avoid binge drinking. That is bad for the heart, bad for your health, increases motor vehicle accidents. We have these holiday heart Queen students being admitted after 6, 12 beers in a night, okay? But up to 1 drink a day, there's no risk. And this is, I'm finishing with the next few slides. This is what the American Heart Association recommends until now. If you don't drink, don't recommend your patients to start drinking because of the benefit. If you drink in excess, drink less and teach your patient about the guidelines. And if you drink light to moderate, you can continue to do so because there is demonstrated beneficial aspects of that. That is true if you leave 2 days of full abstinence. The next 3 studies we did, a survey in Argentina, and we'll pass it very soon. We did it again 1 year later in Uruguay, that small country in South America. And we did it again in Europe, in the Canary Islands. And these 3 studies were done to determine how much doctors know about proper recommendations for patients. And what we systematically found is that they are excellent in recommending exercise, proper diet, elimination of tobacco. But when it comes to alcohol, there is a substantial lack of knowledge. That's why I thank Dr. Crystal and the team of the International Arrhythmia School to give us the opportunity to share some knowledge about alcohol and cardiovascular health and arrhythmias. Thank you very much, and I'm open for questions.
Thank you, Adrian. I think we will move on next part of this professional part of presentation because we're a little over time. It's an excellent overview. I prepared about 35 questions, so we will enjoy it a little later on. Suzette, I want to introduce Suzette, who is co-moderating with me this session. Suzette is a nurse practitioner at Schulich Heart Center, and she's there. She was there before me. In Schulich, and then when we started to work on educational affairs, she's with me in this hard work for about 19 years now. Suzette, please.
Thank you, Dr. Crystal, and thanks everyone for joining us on this Sunday morning. I'd like to take the time now to introduce Dr. William McIntyre. He's an electrophysiologist at Hamilton General. He's a population-based health researcher with funding from Canadian Institute Heart Research, Canadian Stroke Prevention Intervention, Canadian Cardiovascular Society, atrial fibrillation, as well as heart and stroke. He has published more than 100 peer-reviewed journals. Thank you very much, Dr. McIntyre. Take it away.
Thank you, Suzette. Good morning, everybody. You know, Dr. Branchuk, I really enjoyed your talk. You've been a mentor to me for a very long time, but the one question I have hanging out from that was the time of the day, that it's okay to drink. Jimmy Buffett famously said it's 5 o'clock somewhere. So I just wanted to know particularly how that applies on a Sunday. So I'm excited to be here with you all this morning, and we're going to talk about arrhythmia patients and other healthcare procedures. Perfect. I don't have any disclosures that are related to this talk. I've had speaking fees outside from Bayer and Servier. I keep trying to get Eugene to pay me, but he won't do it. So when we think about our arrhythmia patients and why we do arrhythmia procedures for patients, why we do pacemakers, really it's about maintaining their quality and quantity of life. And ultimately, our goal, particularly when we do ablations and install pacemakers and ICDs, is to give patients as normal as a quality of life as possible, to be able to be active and to be able to spend time with friends and family. But of course, patients who have arrhythmias and have pacemakers, they end up undergoing other healthcare procedures because we work to prolong their lives and they run into other bumps along the road. Sometimes they need surgery, sometimes they have cancer, sometimes they need diagnostic imaging, and there comes a certain complexity, and it's our duty as clinicians to support them through these procedures. Now, I think that a lot of other people perceive heart rhythm problems like this as a little bit of a black box. And to think, why is that? Well, a lot of clinicians don't get a lot of arrhythmia exposure and training during their clinical training. Even through cardiology, there's only a few weeks in arrhythmia and pacemaker time. Of course, arrhythmia is a very technology-based specialty. It's one of the few times where we put machines inside people's bodies, and ablation, of course, is very technical. And because arrhythmia doctors are among the smartest and the best looking out there, they can be a little bit intimidating for other folks. So it's really important for us to make sure that we can reach out and support our patients. So I do think that there's sometimes misunderstanding about arrhythmia procedures in patients. The plus side of this is it lends itself well to some pretty good cartoons. You can see here a man on a beach in his bathing suit, which means he's having a great quality of life, but he's being hammered on his chest by his external pacemaker. And he says that the doctor said he wouldn't survive the surgery to implant a regular pacemaker, a surgery that's actually something that's very, very benign and low risk, and few patients who have it in their goals of care really would ever be turned down for such a procedure when it was indicated. So my objectives with you then in our time is to review the approaches to a couple of common clinical scenarios where other healthcare specialists might need support to care for our arrhythmia patients, and look at the specific scenario of a new secondary diagnosis of atrial fibrillation. Specifically, we'll talk about our pacemaker and ICD patients undergoing surgery, getting MRIs, radiations at the end of life, people who are taking blood thinners for atrial fibrillation, the DOACs, undergoing surgery, and then take a peek at that new secondary diagnosis of atrial fibrillation. So here's the next best cartoon. The tiny voices I've been hearing are from my pacemaker. So pacemakers and ICDs in the context of surgery. First, we have to ask the question, how do these things work? Well, a pacemaker continually looks to see if you have a heartbeat, and if you don't, then it gives you one. An ICD, on the other hand, looks to see if you're having a rapid, dangerous rhythm. And if you're having a rapid, dangerous rhythm, it works to do something about it. Simple as that. And the big problem when we get to surgery is this friend here bundled up on the left, electrocautery. In the setting of a pacemaker, electrocautery will bring out a signal that can be picked up by the pacemaker and interpreted as the heartbeat. If the patient happens to be dependent on the pacemaker, that is to say they're pacing all the time, well, then the pacemaker will think there's a heartbeat, so it won't give you one, and we end up with our friend here at the bottom, the flat line or asystole. It's the opposite problem in terms of ICDs. The electrocautery can have the ICD recognize the fast electrical bursts of the cautery, think that it's a potentially lethal arrhythmia, and deliver a painful shock. Because ICDs are programmed to pick up really small signals like ventricular fibrillation, they are particularly vulnerable to this problem. Our friend here is the ICD, our friend here is the magnet. In the setting of an ICD, a magnet on top of the ICD tells the ICD to ignore the potentially fast heart rhythm from cautery. The heart rhythm is monitored by the anesthetist at the bedside, and at the end of the procedure, you take the magnet off. A pacemaker, on the other hand, when you put a magnet on, it goes to asynchronous pacing mode, which means that it's going to ignore the cautery and provide a heartbeat, of course, with the anesthetist monitoring things on top. In a few very special scenarios, the devices might need to be reprogrammed before or after the surgery. This also brings up the list of other things that can cause trouble that pacemaker and ICD patients should avoid. The big things are really, really high voltage equipment, including arc welding, and a few healthcare type devices, such as the TENS unit or transcutaneous electrical nerve stimulation, of which one of the most common versions is our friend Dr. Ho and his pain machine. There's also a long list of things that are absolutely okay, and that's most household devices. The general advice we say is not to continually hug your refrigerator, but the goal of our pacemakers and ICDs are to allow folks to live normal and independent lives, and most things we see don't interfere with that. There's one tiny exception, and that would be cellular phones. These are being produced with larger magnets with time, and the general advice is when you're talking to use the ear opposite of where your device is, and just don't leave it continuously in the shirt pocket on top of where the device is. If you're ever concerned or in doubt about whether or not your device might cause interference, I encourage you to bring it in to the clinic, and we can basically monitor your pacemaker while you've got the device going, and see if there's any interference. Pacemakers are coming now with all sorts of apps. You can see here, this patient has a pacemaker for their heart, and they're getting apps for their liver, kidneys, lung, and pancreas. We're not there yet, but pacemakers are able to monitor more and more things that are related to the heartbeat. So the next one is MRI. This is from a case that we published a while ago. And what you see here is a patient undergoing an MRI. The really big spikes are the real stuff. The little spikes are the oscillatory magnet. And you can see at the bottom from the marker channel, VF, VT, that this device thinks that the magnetic field is actually arrhythmia. And you can only go on to guess what happens next. So when it comes to MRI, there have been massive technological improvements in devices in the last few years. This is to the point where in most places, particularly in Canada, MRI-compatible pacemakers and ICDs are now the standards for our patients. Of course, we have lots of patients that have had pacemakers and ICDs for a number of years, so you need to check in on things. There's 5 situations where MRIs are contraindicated: if the epicardial lead is implanted outside the heart, leads that have been abandoned or capped, leads that are broken or have remnants, or if a patient is dependent on their pacemaker and the device is non-conditional. Now, as I often tell my patients, we have a lot of MRI conditional or MRI compatible devices, but the MRI and radiology departments in our hospitals are not always pacemaker compatible. The approach here is basically to reach out to the clinic that put the device in to see if the device is potentially MRI conditional, and then you have to liaise with the MRI clinic to get it done. Usually this has been done in the background and is highly protocolized. The end of life is the next scenario that is important. When it comes to pacemakers, usually pacemakers are not a big deal at end of life, unless, of course, the patient is dependent. Now, true dependence on a pacemaker is actually relatively uncommon, but in general, we don't need to do anything specific here. Whatever is going to bring the patient to end of life will also bring them to a state where their pacemaker will tend not to capture, it does not cause any pain, and really does not tend to prolong their life. ICDs, on the other hand, can actually be quite distressing if not handled well at end of life. The options are, if things can be predictable and the patient's goals change at the right time, we can turn the ICD off so that at end of life, if there is VT or VF, the ICD won't do anything. Or if we do not have that luxury of being able to get to a programmer, we can get a magnet to use temporarily. It just takes a little bit of planning to work around that. The next is radiation and devices. Of course, our device patients are all living a lot longer. Cancer is a very, very common thing, and adjuvant radiation for different tumor types helps prolong the survival of our patients. The big thing we need to look out for when it comes to radiation and pacemakers is neutron-producing radiation. That's the bluish line at the top. And when we reach out to our oncology colleagues, we want to know if the radiation is going to be producing neutrons. And there's three things to look out here for. You can have transient interference, which means that there's device malfunction only at the time of the procedure. You can have temporary reversion to backup settings that can be reprogrammed, or rarely there's permanent damage. And what we see very clearly in large series is that it's only neutron producing radiation therapy, the one with the big dots at the top, that tends to interfere with our pacemakers. And one thing that's interesting is that the proximity of radiation to the treatment field actually does not predict malfunction. Some of the highest rates of pacemaker malfunction actually happen with abdominal and pelvic radiation. You can see in a large series that the incidence of this overall was about 1.5%. They had mostly just transient malfunction that can be reprogrammed after and dealt with. The HRS, or Heart Rhythm Society, put out a checklist of things to go for, to go over for a patient undergoing radiation therapy. I won't go through it, but just to note that it's something available that will give you a standardized approach. And in the guidelines at the bottom, what's key is that relocation is not recommended to protect the device. The only reason to relocate a device is if it's in the way of the tumor. The next thing I want to chat about briefly is talking about our patients with atrial fibrillation who are taking DOACs and undergoing surgery. Of course, you take your DOAC or direct oral anticoagulant to prevent a stroke. Obviously, if you're going to go and have surgery, you want to be able to get your hemostasis, so we need to interrupt things. The risk is always holding off too long and seeing a stroke. And on the other hand, we don't want to start too early and cause or exacerbate bleeding. There was a nice paper in JAMA Internal Medicine 2019 that showed this standardized protocol for stopping DOACs around the time of surgery. What you basically need to know is which DOAC the patient is taking. You need to know the renal function in the case of a patient on dabigatran, and whether it's a high or low surgical risk procedure. You can stop the DOAC predictably with a general goal of starting around the 48-hour mark, depending on exactly how much bleeding there was during the surgery, and the perceived need for hemostasis. Edoxaban is not on this particular graph, but it would be approached the same as rivaroxaban. And what we saw when they did this protocol, a multi-center with a few thousands of patients, they were relatively high-risk patients across the board with relatively high CHA2DS2-VASc scores and high stroke risk. And the primary outcomes here are on the left. We saw a really low incidence of major bleeding, right around 1 to 1.5%, and very, very low risk of arterial thromboembolism, whether it be stroke or systemic embolism, well below 0.5% right across the board. So this is a simple approach that we can use to stopping and restarting. Of course, with restarting, it requires communication between you and the person and the team who did the surgery. So I think the secret to supporting any arrhythmia patient through an unrelated procedure is communication. And usually this communication should be where two senior people pick up the phone and chat with each other, whether that's the physician, the nurse practitioner lead, or very senior trainees, and where we have predictable interactions, standardized protocols can help with checklists, thinking out ahead of time and chatting with the clinic whenever things are done on an elective basis really helps improve outcomes for our patients. So the final thing I wanted to look at was new onset atrial fibrillation as a secondary diagnosis. So what we see is that often patients who don't have any history of atrial fibrillation are subject to acute physiologic stress. This is often an infection or surgery, be it cardiac or non-cardiac. And frequently, when they're hospitalized for that concern, we see new onset atrial fibrillation for the first time. And it just so happens that as that physiologic stress subsides, sinus rhythm comes back, whether that happens to be spontaneously or at the hand of the clinician through cardioversion. For people and patients like this, well, their atrial fibrillation status is really unknown. They could have atrial fibrillation that was uniquely and directly due to that reversible stressor, meaning it's secondary or benign, or they can have paroxysmal atrial fibrillation, a disease that's well characterized and for which we have a strong evidence base to prevent strokes using oral anticoagulation therapy. We would ask the question, well, how common is this? It turns out in the setting of non-cardiac surgery, when we reviewed this systematically, this happens to a median of about 8% of all patients, certainly higher incidence in patients who are sicker, cared for in ICU, and thoracic surgeries compared to all others. And over the long term, well, anywhere from 0 to 30% of patients tend to actually have a recurrence of atrial fibrillation. And 30% is an interesting number because that doesn't mean that all of these patients have garden variety atrial fibrillation and we can just go ahead and stick them on a blood thinner for life, but it also doesn't mean that we can dismiss them. I think that remonitoring these patients is what's key. When we see the same thing over in terms of acute medical illness, the incidence is anywhere from 1 to 44%, depending on the setting, how sick the patients are, and how they're monitored. And the recurrence rate up to 5 years is in the 40 to 50% range. Again, you have to remonitor these patients and follow them to figure out the natural history of their disease. When it comes to cardiac surgery, things are interesting. On the left, you see the prevalence of postoperative atrial fibrillation according to the day after cardiac surgery. And on the right, you see the incidence. And in both cases, what you'll see is that things level off or peter out by around the 4th week. This means that postoperative atrial fibrillation after cardiac surgery is very much a 30-day phenomenon. We want to make sure it doesn't cause patients problems in the 30 days after cardiac surgery and figure them out in the long term. And here's how I approach AFOS, or atrial fibrillation occurring transiently with stress. First, you have to make a decision about short-term oral anticoagulation based on your perception of risk. I tend to recommend oral anticoagulation when a patient has one or more of a longer single episode of AFib, they have multiple discrete episodes of AFib, if they happen to need electrical or pharmacological cardioversion, or when their CHA2DS2-VASc score is higher. You commit to a short-term strategy, and then we reassess these patients using continuous 14-day EKG after the acute stressor has resolved. So in cardiac surgery, that's usually after a month or more, and usually works out to be about the same in the setting of non-cardiac surgery or medical illness. So I conclude then that arrhythmia patients encounter all kinds of other healthcare procedures. I think that communication with the other specialty is really the key to supporting these patients through their unrelated procedures. And when you see transient new onset AFib as a secondary diagnosis, make up your short-term strategy, but I think it's very important to make sure you reassess these patients when the dust has settled so you can figure out what kind of arrhythmia problem they really have.
Thank you very much, Dr. McIntyre. That's a lot of information, a lot of very useful information. We'll just open the floor now for any questions for both sessions from Dr. Baranchuk's session as well.
Yeah, so everybody is welcome to ask questions for Dr. McIntyre and Dr. Baranchuk, and this is mostly from healthcare professionals because we'll be shortly moving to a patient session. Bill, so that was very interesting talk about transient atrial fibrillation and you know, other challenges which patients with arrhythmia would face. Did you see any differences in terms of stressors, transient stressors? You know, positive versus negative stressors, for example. Is there anything there about extraordinary physical stress, non-emotional stress, so to say? So those are my questions to you.
So I think that's an interesting question. The challenge is we've all seen patients who have atrial fibrillation and some kind of non-medical or non-physiologic stress, if you will. And these are situations where it's particularly challenging to sort out if the patient has a reversible, atrial fibrillation or not. And from a research point of view, that's something that's incredibly difficult to study systematically. All of the data, even on postoperative atrial fibrillation, which is relatively easy to follow, to grab on and collect, tend to be relatively poor. I think that a lot of it ends up being some of the same approach, is that if your clinical suspicion is that there is a reversible stressor, then what you really need to do is follow the patient, let them declare themselves and go forward. Interestingly, there was just an N=1 study at the AHA, where patients were their own controls, and then they were randomized back and forth to go to do or to avoid the thing that they thought was their own self-identified patient trigger. This included alcohol, like wine, but not the type that Dr. Baranchuk sells, sleeping on your left side, caffeine, and they overall found that there was a little bit of a reduction in atrial fibrillation episodes with the avoidance of certain triggers. But interestingly,
it's 11 hours.
Change patients' overall quality of life. So I think what it really takes in that setting is a very, very close discussion with the patient to see kind of what the goals are, and then to follow them longitudinally, and you build a relationship around that.
Thanks. And again, I'm asking you as a medical professional, right? So, there are very few anti-stressor drugs we have in medicine, right? Some of them belong to, I would call it psychopharmacology, and some of them belong to us as beta blockers. And to my knowledge, beta blockers did not really protect that much of patients who are prone to atrial fibrillation from atrial fibrillation. Is your impression is the same, or is there data that if this incidental AFib maybe would be prevented by a long-term beta blocker therapy?
Yeah, it's challenging because in observational studies, obviously the people who are getting atrial fibrillation and then get beta blockers have in some ways already declared themselves, therefore it's confounded. And I'm certainly not aware of any randomized studies for atrial fibrillation ablation or prevention rather, using beta blockers to begin with, right? So it continues to kind of be a confusing and challenging area.
There's a question.
Yeah, go ahead.
No, just a question from the chat, asking Dr. McIntyre if he's performing MRIs or unconditional devices, non-conditional rather.
Yeah, the answer is no right now. In Hamilton, we'll do MRI on pacemakers that are MRI conditional, but not on ICDs that are MRI conditional right now. The main driver of that is a little bit of the discomfort of the radiology and the challenges in giving the personnel support for those patients.
Thank you. There's also another question from the chat for Dr. Baranchuk. What about the golden cure for hangovers, turmeric? It's an anti-inflammatory. Might this change the calculus?
Thank you. I have used this a lot as a spice, I think, or to modify the flavor of foods. But I have to say that I have zero experience in using it for other purposes. So I welcome Blair's perspective on that.
Thank you.
Yeah, I have the only comment I have that I am aware of one randomized effort on turmeric and arrhythmia in coronary disease, and I don't think it was effective. But I obviously cannot comment on the quality of the study, on dosage or on origins of turmeric. Adrian, you gave an excellent lecture about alcohol and cardiovascular disease and arrhythmia. I wonder, what are your thoughts on I would call it genetic or different genetic predisposition to arrhythmia and to maybe chemical tolerance, so to say, quote unquote, to alcohol?
So I'll start with the second part, which I found even more interesting. There are Mendelian analyses that have linked basically same doses with same body constitution and gender differences on how much alcohol induces not benefit, but rather intoxication. So it seems that some people at equal timing for degradation of alcohol experiences the negative effects of alcohol differently than their counterparts. So in that sense, yes, there are studies showing some Mendelian predisposition. Now, genetics and arrhythmias is a huge, tremendous, lovely topic that we can save for February. I'm just guessing, for the
next Sunday,
for the winter arrhythmia school. And maybe we can bring one of our Canadian experts on those topics. We have plenty of people very qualified, from Andrew Cran to Mike Golub and many others that go very deep in the relationship between genetic disorders and cardiac arrhythmias. I think that deserves its proper space.
Let me take you back to Bill's original question. Are you aware of any studies of time of alcohol ingestion and proarrhythmic, incidental, so to say, proarrhythmic activity of alcohol?
This one is for Bill?
Well, it came from Bill to you, so I think.
Oh, from Bill, sorry. Why don't we ask William to rephrase the question? So exactly, go ahead, Bill.
Oh, yeah, I really just wanted to make a Jimmy Buffett quote more than anything else and get the 5 o'clock somewhere in there. But just curious if the timing of your alcohol consumption, really time of day, before noon, before 5 p.m., at 2 in the morning, if there's any proarrhythmic effect linked to the timing of your consumption.
I'm not 100% sure, Bill. There may be something there. I'm more knowledgeable on the 2020-2021 changes on when to prescribe certain medications that we usually were doing just randomly, right? Saying, if a single dose, it could be potentially more protective to take it in the morning because it made sense to us. And now we learn that there is an extra factor of protection if you take it at night. But if you know, please go ahead. I'm not sure. What I could say is during the weekdays for professionals, I could avoid drinking any amount of alcohol. For example, I have lunch in the hospital. I take my own lunch, but I drink a diet pop with that. If you indicate otherwise as my doctor, I may change my practice, but I'm not sure that will represent well in my afternoon patients visits.
All right.
There's a question that I think Melanie answered is from Dr. Sanhueza. Said, nice talk. Thank you very much. What do you think about conditional MRI devices, but with different brands of MRI leads? And Melanie responded to that. Once the device and the leads are not the same company, it makes it non-conditional, no matter how conditional the device is. So that answer was already addressed.
Thanks, Mel, for taking the response. But by the way, Ms. Foisey is the cardiac rhythm device clinic coordinator at Kingston Health Science Center, and she has a specific interest in this topic of the MRIs, and it's a lot of help because she is the one deciding whether these mixed marriages are considered conditional versus non-conditional. Melanie, if you want to say a few words on this.
Thank you. I think the biggest challenge, honestly, is that people can't wrap their head around the fact that the word conditional actually doesn't mean unsafe. The risk profile is, you could have somebody who's a primary prevention, non-dependent ICD that's otherwise fit and healthy, and his system's unconditional. That would be a much safer MRI than, a biventricular conditional system that has high LV capture. Also likely has a huge belly, isn't going to be able to lay flat, and high instances of CHF admission. Like that in my brain would be much higher risk as far as condition goes. So I feel like I'm fighting that battle right now with our radiology, but we've had a couple of really, I was going to say good cases, but unfortunate cases, as it always seems to be that things are, it's when critical incidents happen that change begins to be established. So I think we're moving in the right direction, but really the biggest challenge is the word unconditional. Nobody wants to hear anything else once they hear the word unconditional.
Thank you so much.
No, thank you for your comments. It's important to hear for everyone on this call that it's not just Sunnybrook or UHN or South Lake. We're all in the same boat. We're moving in very, very tiny steps forward. And the most dramatic thing is that sometimes you need this MRI acutely, in neurotrauma and such. And that's where it's literally nail biting, because frequently patients cannot sign consent. And so, yeah, it is hard experience. I think we will be laughing in about 5 years from now on our challenges, because as we were challenged 5 years ago to give pacemaker, which is MRI conditional or not, right? I think we'll be much better in 5 years, but it will take a time. Thank you, everyone. We'll have to move now to the patient's room.
So I'd like to welcome everybody else who is now joining the patient section of this program. Welcome to the International Arrhythmia School session, which is focused on the arrhythmia and alcohol. We are very happy to have so many of you online, and we kindly remind you that making recordings or screen captures is prohibited. Please note that medical practitioners may discuss techniques or products that are not available in all geographies, and we are recording this session for educational purposes. So if you prefer to remain anonymous, you can pose your questions through the chat function in your Zoom control panel. Our moderators will pick up these questions and pose them at an appropriate time in the presentation. It's also possible to ask your questions live through audio. Please indicate you would like our technical team to open up your microphone by raising your hand in the function specifically made in the Zoom control panel. You will find the raise hand function under the reactions button in the Zoom control panel. You can ask your questions at any time during these presentations, and our technical team will open up your microphone, after which it is possible for you to unmute your microphone. Once you have asked your question, please do not forget to mute again. We encourage you to use the opportunity to ask questions to your heart's content. And should you drop off from the event, please know you can always get back in using the same link. It is now with great pleasure that I hand the word back to Dr. Eugene Crystal. Dr. Eugene?
Thank you. Thanks a lot. So I'm, really pleased to see that our room literally doubled now from influx of patients. I hope some of the doctors and medical practitioners who were in the room will not leave, because I think that is the key of today's event. For those of you who just joined, my name is Eugene Crystal. I'm a professor of medicine, and I'm a cardiologist with special interest in arrhythmia. I am working in Sunnybrook and at Women's College, and as some of you may know, I do work in several arrhythmia clinics in the city. I want to introduce Arjun Baranchuk, who is my colleague and professor of medicine from Kingston. Arjun is deeply involved in the research and education of medical professionals like myself. And he published hundreds of research papers and quite a bit of papers in the area he will be relaying to in a moment, and that is about alcohol and arrhythmia. Arjun, please.
Thank you, Eugene. It's a great pleasure and a tremendous opportunity to share this session with Dr. Bill McIntyre and with Blair Henry, who is going to be helping us to moderate this session so he can be the link between us and the patients. So you will see that I'm going, for those that just listened to the prior talk, I'm going to use the same slides, but I'm going to go with a twist to make it a little bit more towards what patients need to know and how we can interact. So Blair, welcome to this session. Please feel free to interrupt during the presentation if you want to make a comment or you want to catch up on a comment from a patient. So before I go to the presentation, I invite you to unmute so you can also welcome our audience.
Thank you, Dr. Baranchuk. It's my pleasure to be here with you and Dr. McIntyre. So I'm sitting from my cottage in the southern part of Nova Scotia this morning. It's we're preparing for very stormy weather, not hopefully unlike the storms that hit the West Coast. So yes, I'll be monitoring the session and looking at questions, and we'll be glad to participate in this. There's also been a number of emails that have been coming in before and during the registration. So if we have time, we'll take a step at those as well. So thank you.
Fantastic. So Blair, we can do it more as a conversation rather than as a presentation from the podium. So at any point for the patients that have joined us today, please use the chat or put your hand up and we can all interact. So I am happy to stop and then to re-engage into the presentation. So thank you very much, Blair, for being here. I'm going to share my screen now. So the idea today, as we said, is to review the aspects that link alcohol with cardiac arrhythmias, but I'm going to do some intro on some aspects of the alcoholic drinks with a special emphasis on things that could be useful for you to understand how much you can drink in a safe manner and when drinking becomes a problem. These are my conflict of interest, but in this occasion, and despite that you will see in Google that I produce wines, one is called QRS and the other one is called QT. and those are Malbecs from the Patagonian region, I make no money on that. And from QT, I donate all my shares to a scholarship to do cardiovascular investigation in Latin America. But if you go across that, I'm pretty sure that Eugene is annotating the names for me to do a specific donation to his team. So today we are going to cover on alcohol and cardiovascular health. I'm going to stop on how a patient can calculate on a standard drink without having to use any formulas. I'm going to bring to earth what are the recommendations from the American Heart Association, which are similar to what the Canadian health institutions are recommending. And then we are going to discuss a little bit about alcohol and arrhythmias as well. And as you can see, in a glass of wine, there are many different components. And some of these components are neutral. Some of these components are not necessarily good for your cardiac metabolism. For example, ingesting too much sugar, we know that is not good. And ethanol is the one that is a complex substance, because if you drink it at small doses, it's quite good for your cardiovascular health, while if you drink it in excess, is very deleterious for your health. And not only your cardiovascular health, because I'm pretty sure that you know that if you drink in excess, your risk of different cancers increases, neurological and psychiatry disorders. And it's quite obvious that if you drink in excess and you drive, you increase the risk of killing yourself and killing others, right? I'm not going to be that obvious. But in the phenolic component, there are a series of substances, and I'm pretty sure that most of you heard about resveratrol, which, if ingested in the proper doses, that helps the functioning of your heart. And in which way? It improves your lipid function. You remember that some of you may be taking statins, and you do that to improve your lipid and avoid that plaques within your cardiac vessels to occlude the flow and to produce a lack of oxygen in your heart and chest pain. It decreases your platelet aggregation, and that means that improves the way that your blood forms clots in a positive manner by inducing a much softer type of blood than the ones that is prone to create clots. It improves your endothelial function. That is the inner layer of your vessels, your veins and arteries. And I'm sure that you are all familiarized with these two terms. It improves the antioxidant and the anti-inflammatory properties of your heart. And that ends up reducing your cardiovascular risk. And for you to understand in more deepness how improves your cardiovascular risk is by 1, improving your lipid profile, 2, improving your inflammation patterns, decreasing the inflammation triggers, 3, improving the inner layer of your vessels, 4, improving your coagulation system, and 5, very important for diabetic patients, improving how insulin modulates the amount of glucose in your blood. And this is true if you drink in moderation, because you drink in excess and your doctor will say, if you're a diabetic patient, either with type 1 or type 2 diabetes, don't drink anything. If you cannot control the amount of alcohol you're going to drink, it's better not to drink anything. And I was telling doctors, it's difficult to calculate what a standard drink is. It's difficult for doctors to remember that and for patients to remember that. The only thing that I want you to retain in your mind is if you decide to have a glass of wine, when you drink red, you are incorporating much more substances than if you're drinking white. And this is important depending where you live. The tolerance of the public health officers on what is a standard drink changes. And you can see that in Canada, we accept 13.6, quite similar to the USA, but the UK is way more strict, while Japanese are more flexible. There's no concordance between recommendations in different countries. So what means drink with moderation? So far, for men, that means 2 glasses a day of wine, leaving 2 days free of alcohol a week. So something that I suggest to my patients is the 2-day resting a week, use it during the weekdays, because maybe you're working and there is no need of that social component that means having a drink, and leave the weekends open for your maximum dose of 2 glasses of wine a day, or 1 can of beer of 330 milliliters, not the largest can of beer that now you can find in supermarkets for only few bucks more. You are tempted because you say, okay, I can have more, but you are crossing the threshold of the recommendation, or 1 shot of spirit. Now, up to today, women are recommended to drink half of men, and we are not 100% sure that the evidence defending or supporting that gender segregation makes any scientific sense. Please understand these are the recommendations to have benefit to your cardiovascular system. These are not recommendations or gender segregations that affect what happened to men or women when you drink in excess. There is enough solid data indicating that there are differences in how much you need to drink in order to get drunk. And one of the things that I think it's very important is to make it visual. 1 can or a pint of beer is 330 milliliters. A single shot, the famous tequila glass, is 40 milliliters. And a glass of wine is this glass. I was telling doctors that I have plenty of patients that come to my office with a very large glass that looks like a fish pot and saying, hey, you say this glass? And I say, no, nobody. It's the regular, the type of glass that you receive in a restaurant. And then there are more to the chemistry of wine than the resveratrol, which indicates there are plenty of substances that could be extracted for wine and to be positive. And this position of full abstinence is a very difficult conversation with patients if you all as a doctor go into the approach of all or none. There is a question. I would like to do a break, Blair, if you're okay. There is a patient that says, I find that presently my atrial fibrillation is under good control, experiencing symptoms lasting seconds or 1 to 2 minutes every 2 to 3 weeks or so. I find, however, if I have less sleep than usual or decrease my exercise routine, my AF symptoms increase. Is this anecdotal or is there something on this? This is a fantastic question. So, so I'm going to go into detail with this, but what I could say is that exercise routines are a clear decrease of trigger for atrial fibrillation. Your experience is not anecdotal. Dr. Bill McIntyre also has lots of experience on how reducing stress reduces atrial fibrillation triggers and atrial fibrillation from a clinical perspective. So you're spot on. That is not anecdotal, and there's research behind it. Thanks for that question. This is to show you that studies at a very large follow-up with including almost 2 million people has demonstrated that if you drink in moderation, there is a suppression or delay of 12 different cardiovascular diseases, including atrial fibrillation, as the case that the patient was highlighting recently, or hypertension or coronary artery disease. What is this resveratrol? The resveratrol is a very interesting substance that is one of the wine components. It's very easy to be digested. This is why there are plenty of research being done in capsules of resveratrol that can be taken as medication. There's still no solid randomized control trials in this direction, but I'm pretty sure that Dr. McIntyre in a couple of years can give us a good perspective on what science is saying. This substance has a very strong antioxidant effect, improves your lipid profile, increases your insulin profile, and it is associated with reduction of total mortality and mortality due to coronary artery disease. And there's, as I said, plenty of research being done on that. I was telling the doctors, and I would like to share with you that, sorry, there was a question?
Yeah, there is a question from one of our patients who would like to ask you to explain postprandial.
Oh, very nice. Thank you for highlighting that. This is when you take medication after a meal. It's your ability. You may recall, I'm talking now to this patient, that there are drugs that we ask you to take on an empty stomach, while there are other drugs that can be taken, for example, after breakfast or lunch, because the absorption in your stomach is good even when you're having food in your stomach. So after a meal, that is the postprandial, meals after having a meal.
Thank you.
And please feel free to interrupt with questions or with comments for all of you. So back to the alterations that you could make in wine. I was talking about in the prior slide, I will put it back again, on the resveratrol, right? That specific substance. So someone was very smart and said, hey, why don't I put a lot of resveratrol in a wine and I can sell it, promoting that this wine, if taken with moderation, is very good for your heart. They did it. I tried it, and it's impossible to drink. That's not wine. That is like a syrup. That is something else that if you like it, good for you. But as a wine consumer of small amounts of alcohol a week, I couldn't have one of those. So the next step that was done with lots of success.
Dr. Banchak?
Go ahead. Go ahead, please.
Well, one of the questions that was appropriate, they were asking how much resveratrol is in QRS wines. So, though you can't add it, sort of to the liking perhaps, but is there a certain type of wine that has more than others? Without biasing,
There is a little bit of a joke there, because QRS, which is the name of the electrical signal, was the name that we picked for the first wine that I have produced. And I was very interested to determine whether I should put extra resveratrol in that wine. And then this is why I found out that in Canada, you can buy wines enriched with resveratrol. If I only remember the name, I could give you the name, but I forgot about it. So, and after trying that, I said, no, I don't want to put extra resveratrol in an artificial manner. So I'm going to make a bracket to tell you this story. There is one way to produce wine that naturally produces a higher concentration of resveratrol per milliliter. And that technique is called hydrate restriction. So basically, a parcel of grapes are going to be fed with less water than what they need for a full deployment. The complexity of that is that you have to maintain the same ultraviolet radiation that you do for normal grapes. So those grapes evolve then into what we call a survival mode. And in that survival mode, without becoming how you call raisins, without becoming raisins, they produce in that survival mode extra amounts of resveratrol. So we analyzed this with enologists and biologists dedicated to that, and the increase in the production of such wines could put these wines in the high end of pricing. So I couldn't convince the two enologists that I've been working so far from two different boutiques to separate a parcel to create the first naturally enriched wine with resveratrol. So give me a couple of more years to find the right person, and I will be able then to tell you whether that tastes good and it's something that could be commercialized, knowing that it brings more of the positive substances. But others thought, well, what if we remove the enolic component of wine? Why, if we take the ethanol out of wine, you only have the positive substances? And that type of wines exist. You can buy it not only in LCBO, but you can buy it in a supermarket. And there's a lot of people that is dieting and they are aiming for losing weight. And when you see the calories of a regular glass of red wine at 125 calories, so basically if you took your 2 glasses a day, you put an extra 250 calories that day, versus 30, 2 glasses, 60. So basically you could have for each glass of regular red wine, a full bottle of the alcoholized wine. So it's not uncommon now that people comes to party, it gives a bottle of regular wine to the host, but they drink the second bottle they brought, which is the alcoholized wine, to be able to socialize without ingesting ethanol. Of course, the psychological, neurological effects of relaxing by taking a glass of wine are not present in this type of products. Let's go to the arrhythmia thing. So for the patients, this is your beautiful ECG. Normal sinus rhythm is what we call the normal rhythm of the heart, with this little bump, the P wave, and this sharp bump, the QRS, that gave name to the first wine I did. And then the interval from the initiation of this peak to the next little bump is the QT interval, and that's the name of the second wine. So, and look how disorganized is atrial fibrillation. And that produces alterations of the dynamic of the heart, but also dramatically increases the risk of stroke, which Dr. McIntyre is going to talk to us. And it is well demonstrated what are the effects of alcohol in the dynamic of the atrium, which is the upper chamber of the heart, disorganizing the electrical conduction. But in this type of curves, what you realize is that the red one is the famous J-curve for mortality. When you drink 10 to 12 glasses a week and you live 2 days free of alcohol a week, look what happened. I put the red arrow so you can see it. Mortality reaches a plateau, and when you start drinking more, your mortality increases. However, it seems that for atrial fibrillation, if you look at the logarithmic curve, which is this blue line, even with a small zip, your risk of atrial fibrillation increases. But when you do a cut of how much atrial fibrillation increases when you drink within the guidelines, look what happened. The relative risk increases from 1 to 1.1, which is the minor amount of increased risk. And now I want to bring the comment of the patient. He or she said, I have atrial fibrillation under control if I do exercise. But what happens if you triplicate the amount of exercise? You may have more atrial fibrillation. And what happens, as you did, when you stop that, you have more atrial fibrillation. So it seems that too much exercise or non-exercise increases the risk of atrial fibrillation. Stress, we will have a full talk on this from Dr. McIntyre, increases the risk of atrial fibrillation. So what could be more stressful than on a Sunday that I should supposed to be going to the farms and looking for good eggs and good cheeses? I'm here talking about medicine and talking about alcohol and atrial fibrillation. That's stressful. However, I do it. Why? Because I assume that increased risk in my possibilities of having atrial fibrillation are still acceptable. So I want to live with that little stress. You guys, most of you live in Toronto. Toronto, it's a big town with air pollution. So if you want risk zero, which could be in this sense, drink zero alcohol, you should also move to the fields to breathe better air. and you should stop working. You should not be relaxing all the time or doing too much exercise. I'm not going to take about the relationship of sex, not sex as genders, of performing a sexual act and the risk of atrial fibrillation. If I keep adding up things that increases the risk from 1 to 1.1, you may decide not to drive a car, not to talk to people, not to exercise too much or too little, not to eat a large amount of food that may increase the risk of atrial fibrillation from 1 to 1.1. With this, I want to be sure that when we interact, doctors and patients, we understand each other on what things and what risks you are eager to take in order to be happy. And the fact that it is heavy alcohol, what the problem is supported by plenty of studies. This meta-analysis, 250,000 patients, indicated that low levels of alcohol intake are not associated with the development of atrial fibrillation. And I could continue with more and more technical data. Doesn't matter if your atrial fibrillation is occasional, paroxysmal, or persistent all the time. If you drink with moderation, the risk is minimal, and even for those patients going to catheter ablation. So I want you to focus now on this graphic. We put the famous triggers of atrial fibrillation classified as green, there's no problem. Lots of papers indicating that coffee could trigger atrial fibrillation, it doesn't. Yellow, those that the evidence is less strong, but they seem that we are okay. So I'm pretty sure that I'm making friends because chocolate seems not to be a potent trigger for atrial fibrillation. And those things that clearly are triggers of atrial fibrillation, and you may say, Adrian, but you have included alcohol here as in red. Why? Because if you drink in excess from what the guidelines recommend, certainly there is an increase on the risk of atrial fibrillation, as well as stroke or intracranial bleeding. So it seems, look at here, that when you drink in moderation, the risk is 0. And when you drink at the maximum of the recommendation guideline, your increased risk is from 1 to 1.1, the minimum amount of increase in risk. So you are the one that has to define whether this is tolerable or not for you. I am going to finish with this. Still, the American Heart Association recommendations are saying, if you don't drink, don't start. But you may say, but Adrian, there are possible benefits of that. So why not? Because the risk of evolving from being a good drinker to a bad drinker are really there. So we prefer that if you don't drink, don't take the risk. If you drink in excess, definitely you have to drink less, not only to improve your atrial fibrillation profile, but your cardiovascular and your total mortality risk. And if you drink light to moderate, you continue to do so. Live 2 days full of abstinence. There was a question about stress. I am going to delegate that question to Dr. McIntyre, that is going to talk specifically about stress as a trigger. And there is another question that says, is there any association between alcohol consumption and the risk of ventricular arrhythmias? Thank you. This is a very important question. I'm going to answer that one first. So ventricular arrhythmias and binge drinking has been demonstrated. This holiday heart that usually it's manifested as young individuals that take 6, 12 beers in a party and come to the ER. Some of them will have atrial fibrillation, but some of them will have ventricular arrhythmias. Now listen carefully. If you have been drinking alcohol in excess for a long period of time, your heart can dilate. It's what we call an alcoholic cardiomyopathy. Is the pumping of the heart gets significantly reduced and you develop heart failure. In that context of a dilated cardiomyopathy due to alcohol, cardiac arrhythmias are a very, sorry, not cardiac arrhythmias, specifically in your question, ventricular arrhythmias are a very common problem. And sometimes we have to even consider implanting defibrillators for that. What evidence supports 2 days of full abstinence? This is a very good question. And as we did a sort of archaeological study trying to determine what was the evidence that women have to drink half dose than men, and we found no evidence. We did find evidence on long observational studies to the 2 days free of alcohol, which allows for at least two things that have good support. One is a full recovery of your liver metabolism, and the second one is for people that drinks above the guidelines. Their inflammatory markers, there is something that we measure called CRP, allows you to, the abstinence 2 days allows you to bring those markers to normal values. So for the 2 days free of alcohol, it seems that we have enough solid evidence. I'm going to pass the next 3 slides very quickly to give time to the next speaker. We did a study trying to determine how much doctors know. So first we did it in Argentina, which is is considered a country with high consumption of alcohol. Then we did it in Uruguay. Then we did it in Canary Island with more than 1,000 doctors. And what we found is that as doctors are very good recommending exercise, what amount of exercise, reducing of stress factors, elimination of tobacco, guiding patients to a healthy diet, there is less knowledge in how we should drink. This is why I accepted this challenge of Dr. Eugene Crystal to bring this topic to the patients, to discuss together an area that us as doctors, we have not developed fully as we did with other offenders to cardiovascular health. Thank you very much. And Blair, the floor is yours.
Thank you, Adrian. One of the questions that might apply to both of you is sort of interesting. Not all AFib is the same as all AFib, and some are mild, some are more severe. Are we talking here to the norm, or are you talking generally this is advice that should be taken across the board, regardless of how you categorize your degree of your illness and the degree of its control?
This is a $1 million question, because basically, if you have sporadic atrial fibrillation and you have 1 episode per year, this is controlled by controlling life habits, as Dr. McIntyre is going to touch in the next conversation. The restrictions for things that are not acting as triggers to you should be minimal, right? If someone says, I go to the gym 5 times a day and I practice 8 hours of exercise a day and I do not have atrial fibrillation, I have nothing to say on that regard. On the other hand, for somebody that has experienced 2 or 3 prior ablations, that is having atrial fibrillation every other day, despite taking antiarrhythmic drugs and recognizing that when they smell wine, they get into atrial fibrillation, I could be a little bit more inclined to suggest that particularly for this case, abstinence could be a consideration. Now, making of that case, of that anecdotal case, a rule that applies for thousands of people that enjoy a glass or 2 of wine a day, well, for that we don't have strong data. So our recommendation should be maybe individualizing a case by case. Right. I invite William or Eugene to make a comment on that.
Actually, Eugene has a couple of questions, so maybe we'll just get him to comment and for his questions.
So I'm unmuting myself. So Adrian, thank you for taking us again through this journey. I love archaeological perspective on that. I think I have more of a comment. One of the issues with alcohol and other things we do is that we find in alcohol a way of managing our lives through the stressful periods, at the end of the stressful period sometimes, to celebrate, whatever we have to celebrate. And there is a big difference between what you do, having a glass of wine twice a week in a nice family settings when everything is okay, and glass of wine at the end of the day, which was extraordinarily stressful, and you expect another stressful week. I think like we have to be very careful about, you know, so to say, a constellation, the overall situation, whereas you know, alcohol is used. Adrian, any kind of wise comments on that?
So I think it's a lovely question, and it's quite generic, and it applies to many different things, not only to that glass of wine, but that conversation with your partner, right? You've been dealing with the pain, discomfort, frustration of 15, 20 patients over the day. You arrive home with all that charge. I want patients to know that doctors are vulnerable. When they call us heroes, I'm thinking in a Clark Kent guy, right? That he can fight the bad people through the day, and he arrives home and says, "Hey, darling," blah, 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 and he's well dressed with his tie. This is not who we are. We are people. We are vulnerable to the suffer of the patients that we encounter every day, and we go back home and we have our own issues, right? Family issues, neighborhood issues. The neighbor dropped his garbage in your side of the fence and stuff like. We experience exactly the same as what the patients experience. But through the day, we've been absorbing all these conundrum of different life experiences that usually are not pleasant. Patients do not come to see us to say, "Doc, I just came to see you from 40K to this town to tell you that I'm feeling great. This is the best day of my." That happens once in a while, but the reality is that we see sick people and people that needs our help. With that, the hero component made us less human. So we go back home, and not only a glass of wine, maybe going for a walk with your partner, taking your pets for a walk, I don't know, exercising, going to your bike and do something, or going to the gym is part of the ways that we release stress, which, as Dr. McIntyre is going to show us, is a potent trigger for atrial fibrillation. So within the combo of things that you may use is a glass of wine at night while you're having a conversation with your significant other, and or watching a movie in Netflix or something like that. And if this is not associated with an immediate trigger of palpitations, of racing of your heart, I see nothing wrong. There is a beneficial aspect for your cardiovascular health, and if it's not impacting your atrial fibrillation, let's go ahead. On the other hand, if systematically every time that you do this, you feel your heart racing, that the heart is going to get out of your chest, well, we may need to figure out how can we help you to eliminate that, or how to remove those triggers. And in those cases, you may find that alcohol, for the specific anecdotic case, is acting as trigger. But I see lots of patients a day. That is my clinical practice. I don't hear this. What I hear is, "Doctor, I have read in the news, Dr. Google, that a sip of alcohol will increase my atrial fibrillation. What does it mean? I cannot drink any more alcohol for the rest of my life? Because I used to have one glass of wine a night with my wife or with my husband. And now I cannot have that. What is left to me?"
So thank you so much for that, Dr. Baranchuk. Just before we switch to the next speaker, I just wanted to quickly bring to the light two questions from patients, which seem to be almost the same. Do the 2 days of abstinence that you mentioned need to be back to back? And what is the evidence that supports this 2-day abstinence? Just quickly.
Very quickly, this allows the recovery of your liver and the decrease of your inflammatory markers, and they don't need to be back to back. They can be spread out over the week. But there is something that the counterpart is also true. I have patients that come to me saying, "I don't drink during the weekdays because I work. Can I have on the weekend the full amount of the week? No, it doesn't work like that. That is binge drinking. You cannot cross the 2-glass wine barrier or the 1-can barrier. My last comment is compensation law. I have patients that say, next Saturday, my daughter is making 16 years of age. Dr. Baranchak, I am going to drink more than what you have recommended me for the last 10 years. What should I do in order not to have a risk of ending up in the emergency room? So we go into what we call the compensation law. Above the mark, for each extra drink that you have to have a drink of the same size that is alcohol-free. That can be water, can be juice, can be a Diet Pop, whatever you like. And then what you're doing is simply diluting the amount of ethanol that enters the body. And believe it or not, this is something that some people that decides, knowing the risks, going into excessive drink that they appreciate a lot.
Thank you very much. I think we'll need to step right over to Dr. McIntyre. Suzette, do you want to just say hello and a few words about
Sure.
Dr. McIntyre?
Of course. Dr. McIntyre is an electrophysiologist at Hamilton General. He's well published and he has much experience in the area of atrial fibrillation and stroke prevention. So the floor is yours, Dr. McIntyre.
Awesome. Thank you so much. Thanks for having me. Okay, let's take some time and talk about having arrhythmias, but also when arrhythmia patients go through other healthcare procedures. I don't have any disclosures related to this talk. I have elsewhere received speaking fees for Bayer and Servier. They're the people that make blood thinners for atrial fibrillation. So when I think about patients in any sphere, whether it be arrhythmia or anywhere else, really there's two things that we want to help them do. It comes down to prolonging their life and helping to preserve or ideally even enhance the quality of life. And this is what we do for our arrhythmia patients. And the reality is that arrhythmia patients often are undergoing procedures in other areas of medicine that are also designed to increase their quality or quantity of life. This can be surgery, cancer treatment, sometimes it's diagnostic testing. And due to the nature of arrhythmia and arrhythmia treatments, there's some very interesting interactions between arrhythmia and each of these different spaces. Now, I think that a lot of people often view heart rhythm problems like this, a black box. Now, this one actually happens to have a lid on it, I just noticed, and the lid can be opened up, but arrhythmia can be a little bit mysterious. The reality is that most healthcare providers don't get a lot of specific training in or exposure to arrhythmia, specifically things like ablation procedures or devices like pacemaker and ICDs are not in the regular curriculum for most healthcare providers. Arrhythmia is really interesting because of our high dependence on technology. It's one of the few places in medicine where we actually put machines inside our patients' bodies to help make them feel better or live longer. And because of this, it ends up being a little bit mysterious to a lot of other people. And it's our job as arrhythmia professionals to try to support other clinicians and patients when they're undergoing other things. So the misunderstanding sometimes of arrhythmia has its downsides, but I do think it makes it for some really great cartoons. You can see this fella here is with his friend on the beach. He's clearly on vacation and enjoying himself, which indicates he has a pretty good quality of life, but he has a pacemaker attached to his belt, and this thing is like a drumstick banging on his heart. And he says, they said I wouldn't survive the surgery to implant a regular pacemaker. And the reality is that a pacemaker procedure is actually a very, very low risk procedure. And there are very few patients who would have it within their goals of care to require a pacemaker that would be turned down for such a thing because of risk. So my objectives in the time with you then is to look at a couple of scenarios that we see as clinicians, and of course, to hear about problems that you might be facing where other healthcare specialists need the support to care for arrhythmia patients. And I'll give you for each a list of questions that I think you should be asking your other non-arrhythmia doctor. And then look at this new secondary diagnosis of AFib in the setting of stress. Specifically, we'll look at pacemaker and ICD and surgery, end of life, the need for an MRI, the need for cancer radiation, atrial fibrillation patients and their DOACs around the time of surgery, and then this new secondary or stress diagnosis of AFib. So here's our next cartoon. The tiny voices that the man has been hearing are from his pacemaker. Well, the reality is they do set off a little bit, a few alarms, but they're usually beeps and vibrations. So pacemakers and ICDs, how do these things work? On the left, our pacemaker. And simply put, your pacemaker looks to see if you have a heartbeat, and if you don't, it gives you one. On the other side is the ICD, implantable cardioverter defibrillator. This continuously monitors your heart rhythm, and if it finds that it is too fast, it will give you gentle pacing or an aggressive shock to get you out of your arrhythmia. The sticky thing is that when you go for surgery, there are things that can fool these devices. And the number one thing that can fool you is this little guy there on the left, the pen, electrocautery. Very, very convenient in surgery to quickly heal wounds and stop bleeding. But what you see on the right with that graph paper and the squiggly lines all over the place is a pacemaker that's been confused into thinking that the cautery signal is the patient's heartbeat. And because it saw what it thought was the heartbeat, it believed that it did not have to give the patient one. And what we actually see is on the bottom, the so-called flat line, or in medicine, we call that asystole, no heart rate at all. This can be something that can be super dangerous. The ICD, on the other hand, again, can still be fooled by the cautery. But here on that printout on the right is what you see is that the ICD defibrillator thought that the signal from the cautery was a rapid, fast rhythm called ventricular fibrillation. And because of this, it charged its capacitor and it gave an aggressive shock that was totally unnecessary. So how do we get around this? The simple answer to this is usually our friend, the magnet. A magnet that you put on an ICD defibrillator at the time of surgery will basically turn off the detection and shock function of your defibrillator. And of course, you have the anesthetist who's taking care of your pain, comfort, and putting you to sleep during the surgery. They are there to monitor your heart rhythm. If you have a pacemaker, then the magnet on the pacemaker will have it do what's called asynchronous. That means that it ignores the signals around and just gives the pacing as if you were predicted to need it. A very simple, safe solution that's available even in rural hospitals to help get patients with pacemakers and ICDs through surgery. So if you have a pacemaker or an ICD and you are undergoing surgery, what I recommend you do is talk to your anesthesia doctor, remind them that you have a device, ask them what their plan is for your device during surgery. And if you're in a situation where it's an elective surgery and there's time to plan, remind them where you are followed for your pacemaker or ICD and help them get in touch with the device clinic to see if there's any specific concerns for you to get you through the surgery. There happen to be a few other things in our daily lives, or well, at least some people's daily lives, that can also trick pacemakers and ICDs in the same way. Anything with really, really high voltage, generator boxes, jumper cables. Arc welding has the ability to fool these devices. Also, the transcutaneous electrical nerve stimulation, or a TENS machine, may be the most popular manifestation of which is the gentleman there on the bottom. That's Dr. Ho's pain machine. Unfortunately, these things will tend to fool a device and are not recommended across the board. In contrast, there are most things in our daily life are just fine. Here, there's long lists of things in your house, from your microwave oven to your television to your hair dryer. None of these things interfere with a pacemaker. I always like to say that you don't need to spend time hugging your refrigerator or anything with an electrical current. But the reason that we give patients devices and design them is so that you can be independent and live a normal life. There is one minor concern with telephones. The technology is always changing in our cellular phones. The iPhone 12, which is the newest, latest, greatest model, had a few specific concerns. And basically, this thing can act like a magnet. So the general recommendation is not to carry the phone constantly in the shirt pocket that's next to the device. Simple as that. Otherwise, you can definitely use it for all of your regular stuff. If you're ever in doubt about a machine that you want to use, ask at your pacemaker clinic visit. And depending on what it is, you can bring it into the device clinic appointment, and your doctor or clinician can actually run the device and then test to see if it interferes with your pacemaker or ICD at the time. A little planning will go a long way. So pacemakers are having more and more functions these days. This one says it's a pacemaker for your heart. You can download apps for your liver, kidneys, lung, and pancreas. The truth is we're not there yet, but there are some pacemakers with some really cool functions, can diagnose things like sleep apnea. They can tell when you're moving and might need a faster heart rate, and they can actually monitor fluid accumulation and predict heart failure. They're not all ready for prime time yet, but arrhythmia is a wonderful technology-based field, and what we're getting is improving all the time. So let's talk about MRI, one of the best imaging things around. So if you see, this is a tracing that is stored on a patient's ICD. And the really, really big lines are the actual heart rate. And then the little squiggly ones in between are lines caused by the magnet rotating around the patient. And if you look at the bottom where you see all those letters, VT, VF, VT, VF, the device doesn't know any better, and it thinks that this patient is having actual fast heartbeats, and it is labeling it ventricular tachycardia or ventricular fibrillation, which are lethal arrhythmias, and it's getting ready to give a shock, even though the patient is in a totally normal rhythm. I mentioned that our technology is improving right now really, really rapidly in terms of pacemakers and ICDs, and we're at the point now, at least in Canada, where MRI conditional devices, both in terms of the leads and the generator boxes, are becoming the standards for what we put in our patients. Now, the challenge is, of course, these things last 10, 20 years sometimes. There are lots of patients that have devices where at least some of the components are not currently pacemaker compatible. And sometimes, depending if you've ever had to have an old lead, an abandoned lead, or a lead put on the outside of your heart, sometimes you cannot get an MRI done. The reality here is that this is pretty complicated. And what you need to do is, if your doctor is thinking about ordering you an MRI, here's what I recommend. So one is, you can always ask the question, is there another type of test that will be able to answer the question? And I chose the word answer the question because it's not necessarily whether it's better or not. It's about, can you get the information you need? There are a lot of non-arrhythmia doctors that think that all pacemakers and ICDs are still a total no-no. So you can remind them that it is possible for some patients. You want to ask your arrhythmia clinic if your device is MRI safe. You want to ask your radiology MRI department if they actually accommodate devices, because different ones accommodate different devices. You'll want to know if you need to be seen in the clinic prior to your MRI. Sometimes we activate a temporary MRI mode that lasts a few hours that basically lets that smart device know that it could ignore the magnet. And of course, you can help your ordering doctor who wants the test get in touch with your device clinic to help make that happen. End of life is one of the other really important times where there's a lot of confusion around pacemakers and ICDs. So the reality for pacemakers is that pacemakers are not life-prolonging devices. They are quality of life devices. So it's usually not an issue to have a pacemaker at the end of life. It will not cause you any pain, and it really won't prolong your life. ICDs, on the other hand, are a pretty big deal at the end of life. What you need to do is know when your goals change and to be able to reach out to get your shock function programmed off. Hopefully, if you see it coming or you've had an overall change in your goals, it could be done at a clinic appointment. Sometimes if you're acutely in hospital, the larger centers are able to program these things off. If you are in a center that doesn't have full device support, then we can use the magnet, just like we saw through surgery, to make sure that the ICD won't give a painful shock at the end of life. So the end of life checklist for patients, and end of life, and I should also say sometimes when your goals change. You want to know if your device is one that might keep you alive longer than you wish, if you have some other illness that is threatening your life. You want to know if the device settings can be changed, and if so, where can it be done? Depending exactly on your jurisdiction, these things sometimes can be done in the hospital that you're in. Sometimes they have to be done in the big clinic where you normally get seen. But there are situations sometimes in some jurisdictions where it might be doable at home. A little bit of planning when it comes up and thinking ahead on this stuff can make sure that you have a really good outcome and your device does not cause you any problems or suffering from that point of view. Radiation. Radiation is something that's very common. Because our arrhythmia patients are all living longer, the downside is they're running into some other problems. And actually the rate of cancers among arrhythmia patients is relatively high, and not because of the arrhythmia itself, but just because there tend to be issues with shared risk factors, and patients with devices get radiation. So what are the concerns here? This dot shows the different types of radiation that can be given on this plot. So at the bottom, you can see there's just the little dots. Those are non-neutron producing radiation. And these things do not cause the devices to malfunction. On the top, what you see is neutron producing radiation, and sometimes these can cause devices to malfunction. Sometimes they malfunction just temporarily while the radiation beam is turned on. Sometimes it changes the programming on the device, and very rarely it causes a problem that we can't change with our programmers. One thing that's important is that the proximity of the radiation treatment has nothing to do with malfunction. So even if it's radiation on the prostate or the pelvis or something far away from where the device is, sometimes it can cause issues if it's doing neutrons. Otherwise, this concern that we have sometimes is if your device is near your tumor, sometimes it needs to be moved. The only reason to ever move a device is if the device is likely to block the tumor. So if you have a cancer in the upper part of your lung, you want to know if the radiation will affect your device in any ways, and of course help connect the radiation oncologist with the device clinic. Most places have protocols in place to be able to get this stuff done, and there's very good checklists from the Heart Rhythm Society to help walk patients and their doctors through this. Next, I want to talk about blood thinners. They're so-called DOACs in surgery. The DOACs you may be familiar with. They're the blood thinners for atrial fibrillation. And of course, we give these to patients who are undergoing, who have atrial fibrillation with the goal of preventing a stroke. When you do surgery, obviously part of your body's been cut and you need to have your bleeding stop and to heal. Blood thinners make you bleed more. So there's obviously a little bit of nuance we need to do the timing to make sure that we stop the blood thinners for the minimum amount of time it takes to help your blood clot healthily without putting you at prolonged risk of having a blood clot that you don't want that could cause a stroke. There's really good evidence now based on whatever blood thinner that you're on, whether it be apixaban or Eliquis, dabigatran, which is Pradaxa, rivaroxaban, which is Xarelto, or even edoxaban, which is Lixiana, which you don't see on this graph, but behaves exactly the same as rivaroxaban. But using this simple table, based on how high risk your surgery is for bleeding, your doctors will be able to give you the right time to stop your DOAC blood thinner and then know when to restart it. As a general rule of thumb, we restart things the next day for really low risk procedures, and usually around the 48-hour mark for high risk procedures. But for high risk procedures, it'll always depend what the surgeon saw at the time. So you want to get your doctors talking about the time to restart. So for patients who take DOACs who are undergoing surgery, at the time of your surgery consult and your anesthesia consult, remind them which blood thinners you take. And if you also happen to take aspirin that often is over the counter and is not on your medication list, let them know. Ask them specifically, when do you take your last dose? And then ask them how they will decide when it is safe to restart their blood thinner. So in general, for patients who have arrhythmias and unrelated procedures, you always want to ask your doctors, is there a chance that my arrhythmia condition or device will affect this procedure, or vice versa? What is your specific plan for my arrhythmia or my device ICD pacemaker around the time of surgery? And remind their doctors that you can help connect them with the device clinic that you go to that has all the details about your device and can offer support for things like MRI or radiation as they're needed. So I wanted to talk a little bit about atrial fibrillation then, and Dr. Baranchak had a lot to say about this. So what is atrial fibrillation? Well, atrial fibrillation is a very specific kind of irregular heartbeat, and it can cause two sets of problems for patients. One is symptoms. Heart racing and palpitations are the classic symptoms of atrial fibrillation, but 1 out of every 3 patients experience atrial fibrillation in a different way. And I'm sure there's people on the call today that all have their own story about how atrial fibrillation makes them feel. And of course, the other big deal with atrial fibrillation is the increased risk of stroke. That's why we take blood thinners like the DOACs. So it just so happens, though, sometimes atrial fibrillation shows up, and as physicians and clinicians, we don't know exactly what to do with it because of the pattern. So in patients who do not have any history of atrial fibrillation, they're often undergoing acute stress, such as from infection or surgery. And in this case, what I mean here is physiologic stress, not emotional stress, but physiologic stress, increased adrenaline, inflammation, pain, dehydration, or having too much fluid on board, things like electrolytes, potassium and calcium being up or down. There's a whole lot of things that can be going on when a patient's sick for another reason. And what we often see is that patients in this setting have a new diagnosis of atrial fibrillation detected for the very first time. And as you heal and that stress, the physiologic stress goes away and your body returns to normal, your heart comes back to sinus rhythm, which is just medical for normal heart rhythm. And at that time, doctors were often confused about your atrial fibrillation. Is it something that was due to whatever the acute stress was, or the main reason that you were sick? In which case it would be something that was benign. And as long as you're not sick like that again, we don't really need to worry about the atrial fibrillation. Or is this what we call as doctors paroxysmal atrial fibrillation, the garden variety of the disease everybody reads about on the internet? And that's important because if that's the case, that means that you're higher risk for stroke and you're likely to benefit from a blood thinner in the long term. We don't really know the answer to this, and it can be very, very different case by case. The goal here, if you have a new diagnosis of atrial fibrillation, my general advice is to ask, is there any chance that your primary problem, be it your surgery or your infection, caused this heart rhythm? You should ask if you need to take specific blood thinners and for how long. And if you think that it's going to be a lifelong problem, or if you need to organize a follow-up visit to decide together if you think that your atrial fibrillation is something that's high risk and you're going to have to take blood thinners for the rest of your life for stroke prevention. So my conclusions for you is that as arrhythmia patients, you encounter all kinds of other healthcare procedures. And the key is really helping with communication. Bring forward your questions, remind your non-arrhythmia doctors that you have an arrhythmia or that you have an ICD or a pacemaker, and get the two of them talking to make sure that your safety is put in together with the right plan. Thanks so much, and I look forward to some questions.
Thank you so much, Bill. This was great. We do have, we're a little on the edge of our time here, so we'll make this quick, but we do have a question that came from one of the patient guests, and it asked made the observation that when they first diagnosed with AFib post-bypass surgery, they found that sleeping on the left side tended to bring on symptoms. But now that it's much better controlled and sleeping on the left side does not immediately bring on symptoms, although they still avoid it. Can you talk to that, and why does this occur?
Yeah, so your heart is in two kind of different phases. Right after bypass surgery, the lining of your heart, so-called pericardium, is irritated and inflamed because the surgeons cut into it. So there's swelling and there's healing goes on. And that tends to trigger atrial fibrillation. And it's very, very normal, frequent to have new atrial fibrillation, or for your existing atrial fibrillation to get worse in the 30 days after surgery. So there's a strong relationship between open heart surgery and atrial fibrillation. Lying on the left side is something that a lot of patients describe. We just had one of the big three heart meetings, the American Heart Association meeting, and they did a really, really interesting study where patients were signed up to a randomized clinical trial to look at their own triggers. So a patient who had different triggers, self-identified dehydration, exercise, caffeine, alcohol, or there were some people, it was lying on the left side, were basically told to go for a week and do whatever, but then go for a week and absolutely avoid your trigger. And what it found is that for things like laying on their side, that actually didn't change how much people had in terms of atrial fibrillation. But one thing I think for sure is that when we go through something and feeling atrial fibrillation symptoms, we feel crummy, and those memories of our triggers end up very much often burned in our mind. And I could totally understand why you still avoid that.
Great. One other question that came up is, can atrial fibrillation lead to ventricular or ventricle fibrillation?
So that's a great question. And I think that there's two sets of answers to that. So number one is there's a very specific arrhythmia called Wolff-Parkinson-White, or WPW, where your heart has a little extra connection or a detour that can conduct very fast. And if patients have the combination of atrial fibrillation and WPW, your heart can go 300 beats a minute, at which time it will basically be overwhelmed and go up and go into atrial fibrillation. That's a rare combination, but if you have WPW and you've been offered an ablation, that may be one of the reasons why. The second one is, can atrial fibrillation lead to ventricular fibrillation? Not usually, but there's a lot of shared risk factors. The number one cause of ventricular fibrillation is having a heart that's been beat up over time from blocked coronary arteries. The risk factors for that are diabetes, hypertension, advanced age, and are very much the same risk factors that overlap with atrial fibrillation. So not usually directly, but there's a lot of shared risk factors between those two things. And both of them are markers of a heart chamber that's taken a lot of wear and tear over time.
That's great. Thank you so much, Dr. McIntyre. I'm sure that there'll be time for there to be many other questions, although just mindful of everybody's time, I'm going to ask the host to come on just to close the session. But thank you very much for this great talk. We very much appreciate it.
So thank you very much for spending time with us. I just wanted to give the word to Dr. Eugene Crystal shortly.
Right. Thank you, everyone. First of all, thank you for the lecturers spending a time with us on Sunday. I apologize for that officially, formally. The origins of the Sunday date are really deeply buried now in some calculations many for ago, which became irrelevant by now. But I'm very grateful for the patient for showing up, as well as for my colleagues. We really wanted to be a relatively small class, and I'm happy to say that we had dozens of patients today. We want to have a little liberty to send you some surveys because we want to know what to do next. We are planning it as a recurring event, and we will try to cover wider areas of cardiovascular health. You already can see on your screens the questions posted. And again, thank you very much for supporting us. Thank you for investing in your own health. That's the most important part. Have a great weekend, everyone.
So thank you so very much for spending time with us. We are now going to launch a short poll so that you can give us some feedback on this particular event. It's 4 questions, and if you could please reply, that would really be helpful for us for future events. You will see them in your screen at the moment, one by one. So let me just end the first question and share with you the results. So we see that the duration was seen as just right at the moment for the majority of our audience. Some felt it was a little bit too short, so that is always a positive feedback, and only a minority thought it was too long. I'm going to give you another question. If you could please answer that as well. When the COVID situation improves, would you join a face-to-face version of this type of event? And I see a very fast result coming in. I give a few more seconds for everybody to respond before I share the actual results. And there we go. So the results were that the majority would be willing to share a face-to-face experience with the same or similar topic. Thank you so much for this. And then there is another question that I have for you. We're already on the 3rd question, so we're making a good time here. The 3rd question, if you enjoyed this event, and I'm going to give you a few more seconds again to respond. I see that we are getting used to responding because it's going very, very fast. And let me just share the results as well. So enjoying this event, I think the majority a lot or very much, and a minority somewhat or neutral. And then the final question that I'd like to ask you is, what about a next event? Was the Sunday a good time or day of the week to do this type of event, or would you have a preference for another event, another day in the week? You can indicate that right now. And I'm just waiting a little bit for everybody to make their choices, because there's multiple choices possible here. And I see most of us have already responded, and I'm sharing the results with you and see that a Sunday is by far the most appreciated day. A Saturday is the runner-up, and during the weekdays also very well possible. Thank you so much for sharing this valuable information with us. We really, really appreciate it. We wish you a very pleasant continuation of your day, and we do hope to welcome you back in a future event. Thank you and have a great day. Bye-bye.
Bye. Thank you all.